Greetings, everyone. I'm Myron Douglas, a health communicator with the Division of Environmental Health Science and Practice and the National Center for Environmental Health at the Centers for Disease Control and Prevention. I'd like to welcome everyone to today's Nexus webinar titled Developing a Surveillance System of Subcounty Data featuring subcounty cancer data. There will be a presentation and a Q&A session with the presenters. All participants joining us today are in listen-only mode, and closed captions are available for this webinar. Next slide, please. Today's Nexus webinar will be available to view on demand. You can find the video recording of today's webinar on CDC's Nexus webpage at cdc.gov/NCEH/EHNEXUS, or by scanning the QR code on your screen. We'll give you a moment. Next slide, please. You may submit questions at any time during today's presentation. To ask a question using Zoom, click the Q&A button at the bottom of your screen and then type your question into the Q&A box. Please note, we often get more questions than we're able to answer during a live session. If you are a member of the media, please contact our CDC Media Relations team at media@cdc.gov or using the phone number listed on your screen. Next slide, please. Please note, the findings and conclusions in this presentation are those of the authors and do not necessarily represent the official position of the Centers for Disease Control and Prevention. Next slide, please. I would now like to welcome the presenters of today's webinar. Our first presenter is Dr. Angela Werner. Dr. Werner is the Science Development Team Lead for the tracking program in the National Center for Environmental Health. She has worked on creating the standardized subcounty geographies for the tracking program and has been working with tracking program recipients and partners to increase availability and accessibility of subcounty data. Next, we have Aaron Vinson. Mr. Vinson is a health scientist with Hite Consulting working in the tracking program. He has supported the tracking program's work to create and disseminate standardized subcounty geographies. His work is also focused on leading the cancer registries and tracking recipients through generating spatial temporal recommendations for subcounty cancer data display. Finally, we have Jane Henley. Ms. Henley is an epidemiologist in the Cancer Surveillance Branch in the Division of Cancer Prevention and Control at the CDC. She uses data from CDC's National Program of Cancer Registries, the National Vital Statistics System, and other surveillance systems to monitor cancer outcomes. Now, I'd like to turn it over to Angela Werner. Dr. Werner, the floor is yours.
Great, thanks, Myron. Thank you for joining us today. My name is Angie Werner, and I will start the presentation. Next slide, please. Today, we'll be talking about subcounty data, so I wanted to start with why this is important. There's a need for more local level data. The Institute of Medicine and Public Health 3.0 have both called on the public health community and CDC to make local level data more widely available, accessible, and usable. Several state legislators have also required their health departments to release local level health data to inform community action. We know that state level data can mask disparities across counties. Similarly, county level data can mask disparities at the local level. Finer spatial resolution data provide locally relevant, reliable indicators for health departments to help implement effective health promotion programs, provide health services, and create community profiles to prioritize needs. In the context of environmental health, we know that counties often cover large areas and there is variation in exposure. Next slide, please. The next couple of slides have a little bit of background about the programs presenting today. Population-based cancer registries collect information about new cancer cases in US states and territories. Some are funded by CDC's National Program of Cancer Registries. Some are funded by the National Cancer Institute's Surveillance, Epidemiology, and End Results, or SEER program, and some are funded by both. These cancer registries cover 100% of the US population. Cancer data are available at many levels, including national, regional, state, county, and congressional district level. We know that many cancer prevention and control activities occur at the local community level, and so more local data is better for planning purposes. Next slide, please. The vision of the Environmental Public Health Tracking Program is to translate environmental and public health data into meaningful information that leads to increased knowledge and actions that result in healthy communities. Tracking's mission is to provide information from a nationwide network of integrated health and environmental data to help drive public health actions. Tracking is unique in that it not only includes the ongoing collection of data for surveillance, but it also includes the ongoing analysis, dissemination, and evaluation of the data. Next slide, please. Through a cooperative agreement, CDC funds 33 recipients to build, maintain, and implement local tracking programs and data networks to grow public health capacity and expertise in environmental health surveillance and to modernize data systems. Next slide. The tracking program has been working on subcounty data for the last decade. We've put several mechanisms in place to work on integrating subcounty data into the tracking network. Our approach has been to work with recipients and partners to have pilot data calls and work groups to develop data standards. When thinking about subcounty data, we know that these data can have reliability and confidentiality issues. We also had to consider compatibility between data and measures, how to deal with increases in data that must be managed, and how we display and message these data. Next slide. In the next set of slides, I'll be talking about subcounty best practices that the tracking program developed in collaboration with our recipients. Next slide. In 2014, there was a tracking subcounty data pilot. We worked with recipients to pilot data submission, and ultimately we ended up with different data feeds, different time periods, and different levels of geography like town, zip code, census tract, and others. We realized this was not going to work well for data and standards around those data. Since that pilot, we've worked to come up with a set of standards around subcounty data and surveillance, which you can see outlined on the slide here, and which I'll be talking about in the upcoming slides. Next slide, please. One of the recommendations from the 2014 pilot was to create standardized geographies. This slide gives an overview of how we thought about these aggregation schemes. Census tract may be too small, which could result in too much suppression or be too unstable, while county might be too large, as I previously mentioned. So we decided to create standardized sub-county geographies, with one aggregation scheme being less conservative for more common outcomes, and one being more conservative for rarer outcomes. This was done in the context of tracking program data. Next slide, please. In creating the standardized geographies, we had various options to explore. The first option, case count greater than the suppression requirement, was ruled out because it would not create consistent geographies across multiple outcomes. You can click once to bring up the animation. So we focused on total population and subpopulation thresholds to explore what worked best. We were looking to maximize the number of geographic units to get as fine a spatial resolution as possible while minimizing instability and suppression. Next slide, please. I won't go through all of these methods in detail for determining the suitable population thresholds, but relevant papers are shared at the end of this presentation if anyone is interested in more information. On this slide, the red lines are the original boundaries and the black lines are the aggregated boundaries. So you can see which census tracts are getting aggregated to create a geography that has a minimum of a total of 5,000 persons or more. Next slide. This is the same idea as the previous slide, but for a minimum of 20,000 persons instead of 5,000. You can see more red lines because more areas need to be aggregated to reach a minimum population of at least 20,000. Next slide. This shows the final set of recommendations that we came up with from our piloting. These recommendations can be used in combination with temporal aggregation to achieve the desired median census tract level case count range. You'll also notice a 50,000 person aggregation scheme that was created after the initial work to address some outstanding data gaps. Next slide. The tracking program geospatial and geoaggregation work groups piloted and talked through all of these potential refinements for the subcounty geographies. The next few slides have some examples. Next slide, please. This shows an example of a potential boundary refinement that was discussed, flagging tracts within the threshold. So we would have flagged tracts that already had 5,000 or 20,000 persons, so they would not be included in the aggregated tracts because they already met the minimum population threshold. This resulted in geographies that didn't really make sense, as you can see here. So on the left-hand side, you can see non-contiguous shapes. There's a little bit of teal color below that larger shape, which would have been considered one unit. And then also on the right-hand side, more of a snaking pattern shape. Next slide, please. This shows the same idea as the previous slide with different examples. So again, on the left-hand side, you see non-contiguous shapes that would have been considered one geographic unit, and then the right-hand side, a snaking pattern shape. So we ruled out flagging tracts meeting a threshold before aggregating. Next slide, please. We use several methods to define areas as rural or urban and then aggregate them. When we did this, this resulted in county boundary crossings and also non-contiguous units. So we ruled this out as well. Next slide. This slide shows our final decisions. The green check marks show what we went with for final decisions and incorporated into the standardized subcounty geographies. And the red X's show what we discussed and analyzed, but did not move forward with for one reason or another. Some limitations of these geographies include that this uses a one-size-fits-all approach for the geographies, the potential for the modifiable aerial unit problem, and dissimilar areas may be combined depending on areas around a given census tract. Next slide. In our piloting work, we realized that we needed some standards around geocoding for sub-county data, which did not exist. The tracking program's geospatial work group piloted this and came up with a standard set of recommendations, including creating a geocoding standards document. Next slide. This slide shows some of the key points that are outlined in the geocoding standards that were developed, including which boundaries to use, categories of precision that were determined through piloting, and how to handle special cases. Next slide. The standards also outline what should be included in the metadata when recipients and partners submit data to tracking. The tracking program has a contract with Texas A&M, which allows our recipients and their partners to use their service to geocode their data. Texas A&M is the gold standard for geocoding data and is always updating their geodatabases. Any data sets would have the potential for data linkage if they're either geocoded to the census tract level, which could be used to aggregate to the standardized subcounty geographies, or if a jurisdiction geocodes to the standardized geographies. We've talked about putting those boundaries into the Texas A&M geodatabases in the future to allow for that capability. Next slide, please. When thinking about subcounty data, we also needed to evaluate population estimates that are currently available. Tract level population estimates are available from a few different sources, including the decennial census, the American Community Survey 5-year estimates for the tract level, private sources like Claritas and Woods and Pool, and then also academic sources like the University of Minnesota. Next slide, please. We're currently in the process of finalizing this work. For these analyses, there are a number of things that we looked at. These include looking at the distribution, so doing a centile value comparison and kernel density plots to answer what is the shape of the distribution between the different census tract level denominator data sources. Do the distributions look similar? Looking geography to geography, so looking at percent difference and identification of extreme tracts to answer whether the rate will be categorized the same or differently by each denominator, and what is the magnitude and difference between one outcome over different denominators. Finally, looking at the applied public health perspective, so generating choropleth maps and looking at indicators of spatial association to answer what are the conclusions that we might draw from the data, what will happen when you analyze the data, and will you come to the same conclusions. Next slide, please. With subcounty data, we had to reevaluate our suppression rules with our recipients and partners. Next slide, please. Specific to our hospitalization and emergency department visit data, we found that the majority of our recipients suppressed 0. We decided to go with the following rule in the data re-release plan for hospitalization and emergency department data. You can click once, please. So our suppression rule for subcounty HOSP-ED is for counts less than 10 or with 100 or fewer persons in the denominator. For cancer registry data, we use the same suppression rule as county level data to suppress for fewer than 16 cases reported in specific population categories or where there are 100 or fewer persons in the denominator. Next slide, please. Finally, with all of our subcounty work, we've had to come up with a standard process for creating display standards to evaluate data and create display and mapping recommendations. We worked with tracking program recipients in 2018 to develop that process and tested the outcomes you see on the slide here. We then used this same process for the subcounty cancer pilot. I'll now turn it over to Jane to talk about the subcounty cancer pilot process.
Thank you, Angie, and good afternoon, everyone. It's really great to be here to share our results from our cancer pilot. Next slide, please. At CDC, the tracking program and the Division of Cancer Prevention and Control, where I sit, have enjoyed a long and fruitful and regular collaboration. Angie reached out to us in 2019 to talk about using the display recommendations from the tracking pilot that she just discussed to display finer spatial resolution cancer data. And just a few weeks later, we launched the first phase of the subcounty cancer pilot. We had 21 registries volunteer to participate, and some registries also teamed up with their state tracking programs. For logistical purposes, mostly time zones for our meeting purposes, we created 3 regional teams. Each regional team looked at lung cancer overall and by sex, male and female, and at a unique set of cancer types. Each team looked at one very common cancer and one fairly common cancer. And so in the pilot, altogether, we looked at female breast cancer, prostate, colorectal cancers, non-Hodgkin lymphoma, melanoma, and liver cancer. We wanted to test multiple display options, as with the tracking pilot. This allows users to look at final spatial resolution data with either more or less temporal aggregation, depending on their interests. For example, someone could look at census tract, but it may be aggregated 5 years or 10 years, Or they could look at 5K or 20K population geographies, and it may be aggregated 3 years or not at all. Next slide, please. The first part of the process was completing a table like this. This helped to show the median case counts for a census tract and then for different spatial and temporal aggregations. You can see across the top we have our temporal aggregations, year 1, year 2, year 3, all the way up to a 5-year period. And in the column we have census tract, a 5K aggregation, and a 20K aggregation. For each cancer type, states discuss the number of census tracts included and the median case counts for each spatial aggregation, and which spatio-temporal aggregations may or may not work for each geographic level. Then the regional team decided on spatio-temporal aggregations to test in the rate calculation table. And I'll go through some examples from our regional teams. Next slide, please. Here we have an example of a completed table from Rhode Island for lung cancer. You can see that there were 241 census tracts. And if these did not have a large enough median case count for a single year of data, but they did seem to have for a 5-year aggregation. There were 119 5K geos, and these again did not have a large enough median case count for the single year of data, but did for a 3 or 5-year case aggregation. And for 20K, we did have enough for a census tract level, or for a single year level, excuse me. Next slide, please. And here we have Missouri and breast cancer. You can see that there are a few more census tracts in Missouri than in Rhode Island, but we still see that a single year of data is not sufficient and we have to aggregate temporally. But a 20,000 aggregation, we do have a large enough median case count for a single year of data. Next slide, please. And here we have Washington State and liver and intrahepatic bile duct cancer. And you can see that there are a lot of zeros and very small numbers in this graph. And even though liver is a fairly common cancer, it's still relatively rare for these aggregations. And so we have to go aggregate up to a 20K aggregation at a 10-year level. And there's always a trade-off between aggregating across space and time. Sometimes if cancers change rapidly over time, it makes more sense to look at a finer resolution spatial data. Whereas if it doesn't change very much over time, it's okay to aggregate across time. Next slide, please. And here's a summary table across all the different cancers that we looked at and all the different regions. And we show the average, median, minimum, and maximum case counts by aggregation level and cancer type. And this helped the states decide what to do for the next step. Next slide, please. For each cancer type, states discuss the median case counts, the percent suppressed for low case counts, and the percent unstable for each spatio-temporal aggregation. Generally, states thought that having more than 30% of geos suppressed meant that the data were not very usable. It meant that too much of the state didn't have a rate. And then the regional teams came up with recommendations for display options. Previously, many participants used an agreed upon suppression rule for consistency in the pilot, and then they also used their own state rule if they wanted to look at that as well. States did these calculations on their own, and so they're using data that were internal to their state. And here we selected the suppression rule that is used for cancer data on the tracking network, which is lesson 16. Next slide, please. Here's an example of a completed rate table from Rhode Island for lung cancer. We have census tract at different temporal aggregations going up to the 20K aggregation at 5 years. And you can see that for census tract for 1 year of data, 92% of the geos are suppressed and 100% are unstable. And so this isn't a very usable aggregation to show. But for 20K at a 5-year aggregation, there is 0% suppressed and 0% unstable. So this is a usable aggregation to use. Next slide, please. And here we have breast cancer again for Missouri. Breast cancer is a little bit more common than lung cancer. And so you can see that we can also look at the 5K aggregations. Next slide, please. And here we have Washington and liver cancer. And again, you can see even at the largest spatial and temporal aggregation, the 20K and 5-year aggregations, still more than a third of the data are suppressed and about a fifth are unstable. Next slide, please. And here's a series of maps. Each registry made maps showing the different spatial temporal aggregations for their cancers. And we have lung cancer at a 5K and 3-year aggregation up to a 20K 5-year aggregation. And this is where you can see the trade-offs between space and time. Next slide, please. And here we have Missouri and breast cancer. And each state also chose their own colors. And so we had a different variety of maps to look at. Here we're looking at a census tract at a 10-year aggregation, 5K at a 5-year, and 20K at a 3-year. And you can see in this last map, it seems a little bit odd that we have so many more areas suppressed. And this is because many of the counties did not reach the 20K aggregation minimum. And we solved this in phase 2, where we aggregated counties up to get a minimum 20,000 population. Next slide, please. And here's a table of the display standards recommended by the pilot participants for spatiotemporal aggregations for each cancer type. They found that many cancers were not able to be feasible to be displayed at a census tract level, except for breast cancer and prostate cancer. And that liver cancer was not feasible to be displayed at any of these aggregations. And you're able to see that many aggregations that could only be shown at the county level do have additional spatial resolution. Next slide, please. We started phase 2 of the pilot in January 2022. We had 23 registries participate and split them into 2 regional teams. We followed the same protocol as in phase 1, but this time we looked at different cancer types and we added a 50K geography. Next slide, please. This table has the display standards tested in phase 2, and you can see that all of these cancers were too rare to be displayed at the census tract level and the 5K level, even with a 10-year aggregation. But most can be displayed with a 3-year aggregation at the 50K level or with a 5-year aggregation at the 20K level. And so there is a trade-off between spatial and temporal specificity. Next slide, please. And these data are available on the Data Explorer for the tracking network. And this is a map of Georgia showing the finer spatial resolution data. The county information is to the left, and a 5K population is to the right. And the cluster around Atlanta, you can see that there's a lot of more finer spatial resolution for the metro area. Next slide, please. And this is the same map with an inset to show detail at the 5K level. Next slide, please. And here's another example from Florida for prostate cancer. You can see the county level is to the left and the 5K population is to the right. And you can see that there's a lot more specificity and you can really zero in on areas that might need more tailored interventions. And thank you. This concludes my section. And the next slide, we'll turn it over to Erin for a demo. Thank you.
Thank you, Jane. Good afternoon, everyone. I'm going to share my screen very quickly and walk through a demonstration of Tracking's Data Explorer and some different features of it. I believe everyone should be able to see my screen. 1 second. So I'm going to give a demonstration of our tool called the Data Explorer. You can access that once you are on Tracking's main website and you scroll down just a little bit and there is this Explore data tile. I do want to mention we have several dashboards available for specific content areas, as well as this info by location tool, which gives tailored information for one specific location if the user is interested in that. But now I'm going to open the Data Explorer and get started. So once you open the Data Explorer, the first thing that will pop up is this query panel. We do have a search feature where you can type in a search string and it will give results of different things you'd like to look at. So if I type in cancer, it'll start populating with different types of cancer. But I'm going to close that and give a thorough walkthrough of how you select data. The tracking program organizes its data by content area. Today we are talking about cancer. So we have different things that could be relevant to cancer, such as environmental factors like air quality or sunlight and UV, as well as different exposures like toxic substance releases, health effects, including cancer incidents, as well as other potential comorbidities of interest, as well as population information for identifying populations of interest around the country. To start with, I'm going to select cancer, and then you have to select an indicator. Our cancer information is organized by cancer site. And today I'm going to select lung and bronchus cancer. And then I can select a specific measure. And for this first query, I'm going to select age-adjusted incidence rate per 100,000 population over a 5-year period. And then I need to select my geography. I'm going to select state by county for a not smoothed age-adjusted rate. Select Georgia, and then I'm going to select this 2014-2018 time period. And depending on the data, you may be able to select an advanced option or a stratification for that data. And I'm going to select male and click go, and this will run the query. As this query is loaded, you'll notice this box at the top. We call this a toast message. And so this will return notes of factors linked with incidents of that queried cancer site. And we have these for all the cancer sites that we have data available for, as well as a link to a Division of Cancer Prevention and Control website that gives further information. When you run a query on the Data Explorer and would like to know more information about the data that you are viewing, you can click this About Data button. And this will open up certain details about the information you're looking at. And if you'd like more detailed information, you can open this indicator and data link page, which will provide information on the rationale for the data source, limitations, uses, and a full history of the measures that are available by the tracking program. The map view is the default view for most data on the tracking portal, but you can also view it by chart by clicking this chart button, and this will typically return a bar chart, and you can customize this, as well as table view depending on the user's preferences on how they would like to view the data. I'm going to switch back to this map view. And then as I've been speaking, you may have noticed this right panel, which allows the user to select to run a second query, which then can allow for instant comparison between two different measures at the same time. On this right panel, I'm going to select data and again, select cancer, the same cancer site, so lung and bronchus cancer. And then for this measure, I'm going to select age-adjusted rate at the 20,000 minimum population level area for a 5-year period. I don't have to select a geography due to limitations. You can only view sub-county data one state at a time, so there is no geography to select, no geography type to select. But I will again select Georgia and the same time period and view it for males and click go. And now we can see that that increased spatial resolution that the sub-county geographies offer compared to the traditional county level data. I'm going to close these toast messages just to get a little more room on the screen. And the first feature I want to demonstrate, I'm going to open this map menu button and then click link maps. And what this does is now these two panels are linked together. So if I hover on one side, it displays that same hover information on the other side. So now you can see both panels at once. And then if I zoom on one side, it zooms on the other side. And then if I pan on one side, it pans on the other. So this really helps when you want to look at one area with two different data up on the screen. So I'm going to highlight this Franklin County area. And one thing I do want to note about these county rates and sub-county rates is that they do use different denominators for calculating those rates. The county data uses NCI seer population estimates as its denominator, while the sub-county data uses the 2010 decennial census population. So there is a slight difference in the final rates, but as we can see here, they are not too far off, but there are differences because they do use different denominators for these rates. I'm going to zoom out a little bit so it's not so busy. And then we still have this map menu open. And now I'm going to select map options. This brings up different options for the map. And the first option I would like to demonstrate is the points of interest layer. Tracking program has many different points of interest available to display. And what I'm going to show today is Superfund sites. So when I click Superfund sites, it adds the EPA Superfund sites to the map directly. And if then I click on one of these buttons, it shows the exact address of that Superfund site, as well as provides a link to that EPA facility report, which can help users identify different areas of interest around the map. The next option I'd like to show back on that map options panel is the overlay layer. There are a few different ones we can look at, and including current radar and active Atlantic cyclones. Today, I'm going to select surface smoke. And this pulls information directly from NOAA and shows where there is surface smoke around the country. So here we can see in Northwest Georgia and surrounding states, there is a little bit of surface smoke currently. This is a live map on that surface. I'm going to close. Oh, no, I'm going to reopen map options. Oh, on this right-hand side. So one of the pieces of feedback that we heard while we were getting ready to launch these sub-county geographies is that, these are small areas that we're not really familiar with. And it's a little hard to orient yourself if you're typically looking for your county on a map and your county is no longer there. How do you find where you want to look at? So we added this boundary layer feature, and you can add the state boundaries as well as HHS regions if that's something you're interested in, as well as the counties. So now I can see the exact counties on this map while still viewing data by the sub-county level. And this helps orient yourself and get to what you want to look at a little quicker. Moving on to some of the last features I'd like to share. You can click this share button here. And this opens up a new panel and has two links here. This first one is a direct link that you can share with a colleague. And once this link is opened, it will open up this exact query in a new browser. So this is a shareable link here, this top link. And then if you'd like to pull this data into software like R or SAS, this is an API query here. And this can be used in an API call, which will then import that data directly into your desired software and allow you to start working with it immediately. If API is not something you're familiar with and you would just like to access the data by CSV, you can click this export data button here, and this will download a zip file to your computer that contains a CSV of the data, similar to this table view here, as well as the footnotes and the indicator template included there. So you have that information handy when viewing it offline. And then lastly, the final feature I'd like to show is how to export an image. If you click this export image or embed button here, a new window pops up and you can import your view directly in a variety of different image formats here. And then lastly, this data visualization embed feature. Once you click that, a new window pops up and you have these different options to set. And you can see here, it imported those points of interest and overlay options that I selected and generates this HTML code. If you insert this HTML code into a web page, I will click preview. It will then insert a widget of that data directly onto that web page and allow the user to embed this visualization. Because I have all of these points of interest open, it kind of zooms to the national level by default. But this will embed a widget onto a web page where that is fully functional and then can be used to on your own personal website. And then that is the end for my live demonstration. So we can transition back to slides. Stop sharing. Thank you. So just transitioning back to our presentation, this is another example of the embedding feature I just demonstrated. This is a new feature the tracking program has developed, and we hope it's a simple, easy to use feature that is also useful for your work. Next slide, please. To summarize the work between our two programs, we here have this summary of the phase 1 work that Jane presented on, as what that was done, that completed in February of 2020, as well as the phase 2 work that we finished last year. And I'd like to highlight these images at the bottom, which show breast cancer incidence. And again, you can see the county level to the right, and then the census tract in the 5K populations on the right side. And again, shows that finer spatial resolution of the census tract in subcounty areas that provides by looking at those geographies. Next slide, please. If you are interested in subcounty data, this is a summary of all of the subcounty data that the tracking program currently offers. I would like to say that community data includes information like age of housing, food environment, land cover and land use, as well as fatal motor vehicle crashes. And the other data here are apparent. Next slide, please. To summarize all the work that Angie presented on of the subcounty of the tracking program subcounty work to help provide solutions to the small area data limitations. We do have those standard subcounty geographies that we've been looking at, as well as the geocoding standards, population estimate standards, and suppression and display recommendations. Next slide, please. We have a few resources to share. These first two are papers that were presented on, or that were published, that capture earlier work by the tracking program when we first started working on the subcounty data and developing aggregations and methodology. This third bullet point is a paper that was just published in June of this year that captures information on the first phase of the pilot project between the Division of Cancer Prevention and Control and the tracking program. And then this final bullet point is the CDC Tracking Methods Warehouse, repository, which is a GitHub page that offers the documentation on tracking programs methodology, as well as the shapefiles and supporting documentation to actually use the tracking program geographies in your own work. These are publicly available and available for use for any reason. So we hope that these are helpful to have access to. Next slide, please. And finally, our acknowledgements. Within the tracking program and Division of Cancer Prevention and Control, we've had a lot of help from other colleagues, as well as CDC colleagues across the entire agency. And we have also worked very closely with tracking program recipients and cancer registry staff across the country. And all of this was facilitated by Ross Strategic, who this would have been impossible without their help in logistics, meeting scheduling, note-taking, and meeting facilitation. Next slide, please. And here we have our contact information for myself and my co-presenters, as well as some links to the tracking program's social media and webpage. This is our final slide, and back to you, Myron.
Thank you all so very much. Let's see, question. Here we go. Sorry. Now we are at the question and answer portion of our presentation. I will have the presenters, reshare their videos and voices for us. Thank you for those who have submitted questions into the chat feature as well as the Q&A. So we will go through those questions as they came in, and we'll have the presenters present on them. Let's see. The first question is from Don. He asked, do you consider doing any small area estimation rather than just aggregating multiple years together to estimate for small geographies?
I can start with that, and then others can chime in. But yeah, we initially created these geographies without modeling, smoothing, or other estimations, estimation methods based on, I guess, census tract level data availability, input from our recipients, so those work groups that I talked about that we had over the years, and then also thinking about facilitating user understanding and ease of interpretation. I think we also found when we were reviewing the literature and potential methods around this, some of the literature was suggesting low precision for rates that were estimated, and some of their conclusions were around aggregating census tracts into larger areas, which is what we ultimately did. The background references in that slide that Aaron shared go into more detail. But then having said all of that, we are also talking about kind of another phase of piloting recommendations that came from some of this previous work around looking at small area estimation to do that as a project with both the registries and tracking recipients. Jane or Aaron, I don't know if you have anything else to add to that.
Nothing from me.
Just to add that some states do the small area estimations on their own, and we can provide references for that from our heart disease division.
Great, thank you all. This next question is from Pamela. It's either for Jane or Aaron. It says, would the creators consider adding a municipal level for the maps? It would be helpful in putting the mapped subcounty subcounties into context.
I think that is something we could consider adding. What the difficulty in that is that it would need to be available nationally. And I'm not sure if every state uses municipalities in the same definition. But basically, if that is something that census does have a map for, we could probably get that added if there is a need for that. Yeah.
And I could add to that that we do have some states have used the geos created by tracking and have shown the data on their own websites. So that's always an option to use it, our crosswalks on your data.
Awesome, thank you all. And to follow up on that question, how does one identify the CTs of each subcounty? This would be important in describing and documenting the subcounty maps and data.
Yes, so that's census tracts, if you're not familiar with that, if
was
that
not.
acronym. Yeah. And so on that GitHub repository, we do have the full crosswalk available for use. And that is the best location to look at which exact census tracts are aggregated into those larger subcounty geographies. It's not a function we are able to have on the portal itself to be able to view which census tracts make up those larger geographies. But that crosswalk is available, which has, I believe, every single census tract designated by the census. So you can then easily see which census tracts are grouped together within your state.
Awesome. And to follow up on census tracts, when you hover over a subcounty, often there is a 3-character number. Does that identify a group of census tracts?
Yes, so the 3-character number is a string of digits that is a unique ID for that geography in that state. Those 3 digits could be the county FIPS code if when looking at the subcounty map. Sometimes that is just the county itself. So that could be the county FIPS code or some other unique string. So it's really just an identifier to be able to, when you are looking at data in the table format, or once you pull it into a software to look at it yourself, to keep those identified. On the map, it's kind of just there for awareness and making sure that those geographies are identified uniquely.
Got you. Thank you. And just a reminder to everyone, if you are looking to submit a question, please use the Q&A button at the bottom of your screen to submit your question in the Q&A box. The next question is, what is the platform or software that has been used to create dashboards on the Data Explorer webpage?
So I only know a little bit about this because we're not the IT team, but I know some of the IT team are on the call, so you can feel free to chime in the chat or correct me. But it's a combination of custom built and out of the box. So I think the front end is based on Angular and HTML5. And then we use components like AnyChart or Open Layers. And I think everything runs on Microsoft servers. So like I said, the IT team can correct any of that or add to that. Aaron, I don't know if you have anything else to add, but.
That all sounds right to me.
Yeah, so there we go. There's a little bit more information in the chat then.
All righty, thank you to Craig for providing some more insight on that. Next question, do you mind sharing again the difference between smooth and not smooth data and pros and cons for them?
Yeah, so basically the big difference is when looking at smooth data, that's data, those are rates to be viewed on a map. If you were wanting to present a rate in a paper or to the public or something like that, the smooth rate is not the appropriate rate to provide. It's actually that unsmooth rate for that county itself. Basically what a smoothed rate is, so let me start with the non-smooth rate, right, is just that individual county or whatever region you're looking at by itself. To calculate smoothed rates, you pull the data from not just your county of interest or whatever that region may be, but also the ones that physically touch it. So on the map, all the ones that it shares borders with, right? So now you have this kind of pooled data, and that smooths the data across the map. But when presenting the actual health data back to the public or whoever it may be, you want to stick to that non-smoothed rate, because that is the county of interest or whatever it may be by itself. So smooth rates are good if you want to for visualizations and for viewing on maps, but the non-smooth rate is what you want to use for reporting.
Awesome, thank you for that. Our next question is from Cynthia. How does this methodology differ or not from the non-cancer incidence rates on CDC's places, with the example of the BRFSS data model to track level?
So I can take this one. Let's start it off. The data on the Data Explorer are using submitted census tract level data. In every state, there's a central cancer registry, and every cancer case is reported to that registry and then reported to CDC. And the places data are higher level data modeled down to the census tract level. And additionally, health outcome data and the BRFSS are self-reported data, and they generally measure prevalence rather than incidence, whereas the Data Explorer shows incidence data.
Thank you. Let's see. Another question came into the Q&A box. I noticed that the race and ethnicity for white includes Hispanic. Will these categories be able to be further divided in the future?
So I can take that one as well. We're evaluating changes as they happen, especially with the revisions to the OMB race ethnicity categories. And we're seeing what can be feasibly be displayed without suppressing data. So more to come.
Thank you for that, Jane. Roseanne asked, how are you handling changes in census tract boundaries over time when the 2020 census has altered many census tract boundaries?
Yes, that's a good but challenging question. So I think the most straightforward answer to that, I guess, is just that our mapping platform does adjust to new boundaries. It's really a matter of what boundaries the data are geocoded to. So that's the easy part. I think the more difficult part is which boundaries do we geocode to? How do we handle things like the rolling year rates and figuring that out? So we're currently in the process of setting standards around that, working with our recipients to pilot solutions and seeing what we want to do around that. Like I said, especially with things like rolling year rates. We also have with 2020 census, figuring out how to handle and message differential privacy where noise is being injected into the denominator, and a few other issues. So we're in the middle of all of those conversations right now.
Thank you so much. We have time for one last question from Barbara. Will the subcounty aggregations of census tract remain the same when looking at the data versus different years? Also, will they be the same for different cancers?
So as long as those, the current subcounty geographies we have are based on the 2010 census tracts. We do have some modifications where we are able to incorporate slightly different census tracts that maybe have appeared in 2015. But these geographies are intended to be used for data 2019 and prior. Starting in 2020, as soon as we're able to, we will, we will create a new set of geographies for each decade. So we hope to soon develop geographies that will be used for 2020 data to 2029, and then proceed in 2030 and so on. And these geographies do remain the same across cancer site, cancer type, and other data. So they were intended to be agnostic to the data being displayed. So, and it can be used for health data. It can also be used for exposure data and population data as well. So you can map any data you'd like in these subcounty geographies.
Awesome, thank you. Next slide, please. I would like to thank everyone for joining us for today's Nexus webinar. Special thanks to Angie and Aaron and Jen for Jane, excuse me, for a great presentation. If you have any questions about today's presentation, please send them to Nexus, that's EHNEXUS @cdc.gov. Thank you all so much, and we hope you'll have a great rest of your day.